The first thing I want to talk about is why we have third molars. When looking up why, they say having a third set of molars was vital for our ancestors to allow them to eat coarse raw foods necessary for survival. The larger jaw that was common in our ancestors could easily accommodate the wisdom teeth. Wisdom teeth were basically the evolutionary answer to the need for chewing power to combat excessive wear with this food they were eating. When looking at wisdom teeth from a developmental standpoint, wisdom teeth start developing between the ages of 7 to 10 when the tooth germ becomes evident. Over time, at about 11 years old, mineralization of the crown begins with the occlusal surface facing anteriorly. Crown development is complete at about the age of 14, and this is when root development starts to begin. Root development is about 50% complete by the age of 17, and by the age of 25, root development is almost completely complete with the apex of the tooth closing. A lot of information about wisdom teeth can be found, but one of the main sources we use is a paper that was written by the American Association of Oral Maxillofacial Surgeons. The literature review, which they did, was done in 2007 and updated in 2014, and it was more or less a review of current literature regarding the different aspects of third molars and their removal. And a lot of the stuff I'll discuss tonight comes from this paper directly. The first thing I want to go over is different risks with having impacted wisdom teeth. The first risk is periodontitis. Another risk is pericoronitis. Caries is very common in wisdom teeth. Crowding, development of cysts and tumors, damage to adjacent teeth or root resorption, as well as jaw fracture can actually be a little more common with impacted wisdom teeth. So the first topic is periodontitis. Pocketing of greater than 5 millimeters is 2 times more likely to occur with an impacted third molar. About 25% of wisdom teeth patients who perceive themselves as asymptomatic actually already have inflammatory periodontal disease. And another important fact is after removal of impacted wisdom teeth, you're more likely to develop a periodontal defect distal to your second molars when you're above the age of 26. You just don't get as good of a bony fill in that distal aspect of the second molar as you get older. This first pan here is a patient of mine. Is a 58-year-old male who was referred to me by his periodontist for evaluation of teeth 17, 18, 31, and 32. There's obviously a lot going on here. You can see some caries on number 17. He has resorption on 32. But what's most striking is the amount of periodontal disease you see between 17, 18, 31, and 32. And it was clear that there was no way to save any of those 4 teeth. All 4 of those teeth were removed. All that inflammatory tissue was cleaned out, and the sites were grafted in preparation for implants in the future, as well as to try to fill the defect that he's going to have distal to number 19 and number 30. This next patient is a 34-year-old male who was referred by his general dentist for extraction of just tooth number 32. The patient is a physician, and at consultation, I discussed with him what I saw going on with tooth number 31. As you can see, he has bone loss on the distal aspect of tooth number 31 to the apex of the tooth. And my feeling was that once we took out 32, tooth number 31 would be completely hopeless and be a matter of time before he lost the tooth. And the patient agreed that at the time of taking out tooth number 32, it made sense to remove tooth number 31 as well, graft the site, and prepare for a dental implant in the future to replace the tooth for him, as that would be a more predictable solution than trying to maintain tooth number 31 over a long period of time. The next indication for removal of third molars, which is probably the most common reason we see patients for emergency, is pericoronitis, which is inflammation of the tissue surrounding a third molar. Pericoronitis occurs when the wisdom teeth do not have enough room to erupt through the soft tissue into the mouth. When that happens, you get a soft tissue operculum covering the distal aspect of the third molar. You get food bacteria underneath that flap of tissue, and then you have pain. As you can see from this X-ray, you can see the picture, you can see the tissue overlying that third molar is inflamed. This first panoramic radiograph is a 26-year-old male who came in about 2 weeks ago complaining of pain with his number 32. From looking at his pan, you can see all of his wisdom teeth are at the same occlusal plane as his second, first molars, and premolars. And from looking at the X-ray, one would think his teeth came in nicely. However, you can only see the front the mesial 50% of both his lower third molars, and he had a pretty significant pericoronitis associated with tooth number 32. At that visit, we did take out tooth number 32. We also took out tooth number 1 to prevent supereruption, and the patient is scheduled for removal of teeth number 16 and 17 in the upcoming weeks to prevent what occurred on his lower right side. And what is really striking in this X-ray is one would look at these teeth and say they're coming in perfectly, he shouldn't have any issues, but he clearly had an issue that made him come in on a Friday afternoon in pretty significant pain and discomfort. The next X-ray is a patient I actually saw on Monday. He came in having a lot of pain on his lower left side, and when he saw his X-ray on the screen, he initially pointed to tooth number 32, thinking that was his left side, and that tooth looked worse to him, and he thought was causing his pain. But again, similar to the previous patient, you can see his tooth number 17 looks like it's erupted completely. It's almost at the same height as teeth numbers 18 and 19. However, the distal aspect of that third molar is completely covered by soft tissue, and he had a pretty significant case of acute pericoronitis. Similar to the previous patient, for this patient, we did take out teeth numbers 16 and 17. The patient is due to follow up, and we will discuss what should be done, if anything, regarding teeth numbers 1 and 32. This last case of pericoronitis is a little bit different. This patient came in again with pain and discomfort on her lower left side associated with this erupting tooth number 17. What concerned me when looking at her pan was if you follow the inferior alveolar nerve canal, you can see when it overlaps with her third molar, you can see darkening of the root. Darkening of the root is a very telltale sign of the inferior alveolar nerve being in very, very close contact or in direct contact with the root of the tooth itself. In this case, we decided to take a cone beam CT to further evaluate the position of the nerve in relation to the tooth. As you can see on this axial section, the nerve is compressed against the lingual plate and is sandwiched almost between the lingual plate and the root of the second molar. After discussing with the patient different options for this tooth, we decided something has to be done, but the risk of nerve injury with removal of this third molar was too high for the patient, and we opted for a coronectomy. A coronectomy is when we surgically remove the crown of the affected tooth. We bring the remaining roots 3 millimeters below the adjacent bone, and we obtain primary closure over the root. The goal is for the soft tissue to heal completely over the root that remains, and for the patient to not even know the root is there. This is the post-op x-ray showing the retained root. This patient, I saw her last week, which is about a month out from the procedure. She had complete soft tissue coverage over that root of the remaining tooth. She had no pain or discomfort. The patient will be followed because what can happen sometimes with these coronectomies is the root can actually start to shift up. If the root starts to shift up, the patient may feel like another tooth's erupting in the mouth, and at that point, we have to go back in and remove the rest of the root. If that happens, that's not actually a bad thing because now the root has shifted away from the nerve, and the root is typically loose within the socket and can be removed with minimal risk to that nerve. The next issue we see with wisdom teeth is caries. This bite wing is a patient I saw last week who was in her second trimester pregnant, who came in with pain associated with that erupted tooth number 1. The issue with wisdom teeth is they're pretty far back in the mouth and they're very hard to keep clean. And about 15% of third molars extracted, caries is seen. In this case for the patient, since she was in her second trimester, which would be the ideal time to remove the tooth, we did remove the tooth with local anesthesia. Once the patient does deliver, the patient is going to follow up for a pan to further evaluate her other third molars to avoid any issue like this in the future. But since she was pregnant, we tried to do as little as possible for her to get her out of pain at the ideal time, which again is the second trimester. The next patient that came in is a 34-year-old female. She came in because she was having pain on her lower right side. But as you can see, she has caries on 1, 17, and 32. For this patient, she only wanted to treat number 32. She was very apprehensive. We did take out 32, and as you can see, she has pretty significant decay on the distal aspect of number 31 as well that will likely need a root canal and crown on this tooth. And you can see how if these teeth were removed at an earlier age, she likely would have not had caries on this teeth, would not need a root canal tooth number 31, and her oral hygiene would be in much better condition. The next topic, which is a little controversial, is crowding. A lot of times we see patients who just finished or about to finish ortho, and they come in stating they want to get their wisdom teeth removed to prevent their teeth from shifting in the future. And I make it very, very clear to the patient that while I do think it does make sense to remove the wisdom teeth, that taking out the wisdom teeth alone will not prevent their crowding in the future. That if they don't wear their retainer or have some lingual wire or something to maintain the teeth will still shift. This quote is taken from that position paper written by the American Association of Oral Maxillofacial Surgeons. And what they say is, despite good intentions, we are not able to explain, predict, or prevent dental crowding, no matter what the cause. While it is likely that third molars play a role in the etiology of crowding, they are only one factor to consider in making a clinical decision about third molar management. Therefore, it is prudent for clinicians to educate patients that the cause of dental crowding is multifactorial, and while third molars may play a significant role in some patients, the current state of knowledge does not allow us to identify with accuracy who is at risk, which basically says other things can cause this. Wisdom teeth may need to be removed, may not be removed, but crowding alone wouldn't be a reason to just remove the wisdom teeth. The next issue we see sometimes with impacted wisdom teeth are cysts and tumors. And the incidence of neoplastic change with impacted third molars can range anywhere from 1.5 to 13%. Most literature has the percent around 3%. And wisdom teeth develop in a follicle, which is a little sac. And when that sac gets larger, that is when you're considered to have a cyst. It's considered cystic if the follicle is greater than 4 millimeters. Now, in this pan here, I put this here because this patient does not have a cyst. But if you look at her lower right side, that impacted tooth number 32, you can start to see the distal aspect of that follicle is starting to enlarge slightly. And the question is, if this tooth is not removed, does this tooth have some potential to develop a cyst in the future? And that is why when teeth look like this and you start to see an enlarged follicle, you may want to think about removing the wisdom teeth. Additionally, you can see the other wisdom teeth may not be in an ideal position, but I just wanted to point out that you can clearly see this follicle that the tooth is developing in. This next patient is a 69-year-old female who I saw about a month or two ago, and she came in with a draining fistula in her lower left posterior mandible. When we took a pan, you could clearly see she has an impacted tooth number 17, which shows signs of resorption as well as a radiolucency around the crown of that impacted tooth. I discussed with the patient she would definitely need definitive care for that impacted wisdom tooth, but due to the position of that wisdom tooth, we would also need to remove tooth number 18 due to a bony defect she would likely have in that area, as well as access to that impacted wisdom tooth. We did take out tooth number 17, tooth number 18, remove the cystic lesion in that area. We protected a nerve with a membrane and then grafted over that site. The cyst was sent out to pathology. It came back as the lentigerous cyst, which is a benign, common cyst you see with impacted wisdom teeth that does not need any additional treatment besides removal of the cyst and removal of the offending tooth. This patient, although we did visualize the nerve during the surgery, she had no neurosensory issues post-operatively. But again, you can see by removing this tooth in the future when she was younger, she may have not had to lose number 18 at this time. This next patient is a 72-year-old female who was referred by her general dentist for extraction of tooth number 1. Now, when she came in to see me, she did not have a pan. She came in only with a PA of tooth number 1. And what happened with tooth number 1, it was starting to break through the soft tissue a little bit, and she was having some discomfort there. Personally, I'm a lot more comfortable taking out wisdom teeth with a pan, and we decided to take a pan just to get better evaluation of tooth number 1. To my surprise, you can see she has a very, very, very large radiolucency of her left mandible that extends all the way up to the coronoid process, as well as her condyle. Looking at this X-ray, the first thing that goes up on my differential is an odontogenic keratocyst. So after speaking with the patient, we decided at the same time that I would do an incisional biopsy, I would also place a decompression tube within the cyst. If this does come back as a odontogenic keratocyst, by having a decompression tube there, we can ideally try to shrink the cyst to get it to a more manageable point. Because at this point, the only way to treat this cyst would be to resect her mandible, which is a pretty morbid procedure. By possibly shrinking it down, we could try to remove some teeth in the area as well as the cyst without giving her a continuity defect of her mandible. The biopsy did come back as a keratocyst. She's about 3 months out from the biopsy and the decompression tube. I saw her recently. We repeated the panoramic radiograph, and we do see some shrinkage of the cyst itself. The patient is aware that this is a long process, and we're going to leave this tube in a lot longer to see how much we can get this cyst to shrink down before figuring out what definitive care she needs. Looking at this x-ray, you may also be concerned about pathologic fracture of the jaw, and she definitely is at some risk for pathologic fracture. But if you do look at the cone beam scan, she doesn't have much thinning of the cortex. Her cortex is still pretty thick. So while she's definitely at increased risk, I'm not too concerned about a pathologic fracture at this point for her. The next thing I want to talk about is damage to adjacent teeth or root resorption. As you can see in this x-ray here, this patient has erupting 17 and 32, which are erupting into the distal aspect of his second molars. And you can see it's pretty significant the caries he has on the distal aspect of these second molars. In this case, we did take out the third molars, and the dentist was going to further evaluate the second molars to see if they were restorable or if they had to be removed. But you can see tooth number 31 looks in much worse shape than 18 and likely may not be restorable. And by taking out wisdom teeth at, again, a younger age prior to the eruption of these teeth, we could prevent these issues for patients. The next thing is jaw fracture, and I would never recommend a patient take out the wisdom teeth solely for the reason to prevent jaw fracture. Jaw fractures happen even in patients without impacted wisdom teeth, but you can see patients are almost 4 times more likely to fracture their jaw if they have an impacted third molar, and 5 times more likely in the when there is a partially impacted third molar. In this case, you can see the patient has a right parasymphysis and a left angle fracture going through that impacted number 17. The fracture was plated. Would the patient have still broken their jaw if the tooth was there? We never know, but having that tooth there does not help even in trying to treat the fracture itself. This next picture is another left angle right parasymphysis fracture, and you can see this patient's younger, 24 years old, and you can see how the fracture is running right up to the root of that impacted third molar, and it makes you think if that tooth wasn't there, would he have still broken his jaw? Again, we don't know, but there definitely is an increased risk of jaw fracture with having wisdom teeth. It's just one of the many factors we look at with taking out wisdom teeth, and again, I wouldn't say take out wisdom teeth to prevent jaw fracture, but just something else to think about. What I really want to stress with wisdom teeth is asymptomatic does not mean disease-free. Even third molars that have erupted into the mouth in a normal upright position may not be problem-free. Their location in the back of the mouth makes them extremely difficult to keep clean. Bacteria that causes periodontal disease may exist in and around asymptomatic third molars, leading to damage before symptoms even occur. And pathology is always present before symptoms occur. As you can see from both patients that had cysts, especially the large one, the patient had no idea she had anything going on there. She came in for a tooth on the opposite corner of the mouth. And a lot of times, once damage has occurred, it's too late and it may not be treatable. Now, when should wisdom teeth be removed? Developing wisdom teeth have an incomplete root system and are typically still within the dental follicle. It's best to take out wisdom teeth when you have about 1/3 to 2/3 root formation. When you have less root formation, you try to remove the buds of the wisdom teeth, you typically get into situations where the crown of the tooth starts to rotate in the socket, and it's slightly more difficult than when you have some root formation that prevents rotation of the crown at the time of taking it out. The fact that the teeth are still within the follicle is actually beneficial because the follicle does create some space in the area, which allows you to take out the teeth possibly with less bone removal. But also by taking out wisdom teeth at this stage, the surgery is less complicated. There's decreased operative time, fewer anesthesia concerns as patients are typically younger, and there's improved healing capacity because the patient's again younger. We typically see that patients who are in their late teens, early 20s, you see about a 3 to 5 day recovery to feel pretty good. As you get older, about 21 to 25 years old, it takes about a week to feel back to normal. In that 25 to 35, it's definitely a tougher recovery where almost even at a week, they're still feeling it. And it's the next few days where they start to feel better. And once you get past about the age of 35, it's about 2-3 weeks to they're feeling better. Those teeth don't want to come out. They're completely formed teeth, and you have to put a lot more force and remove a lot more bone to remove the teeth. There was actually a study which was mentioned in the white paper of 4,000 patients that showed about a 1.5 times likelihood of a complication if the patient having third molars removed is over the age of 25, with generalizing increased risk up to the age of about 65. They say about 65, the risk is the risk, and there's not much change at that point, but definitely taking it out before 25 is beneficial. This x-ray is a 16-year-old female where you can see about 50% root formation. The teeth are sitting nicely above the nerve, and you can see they're sitting in the follicle where you have some space to remove. Teeth like this are kind of the ideal teeth you want to see to remove. The patient has no symptoms, there's no pain. They can come in for a consultation. It can be scheduled at their convenience, what works with their school schedule, and it's not an emergency on a Friday afternoon or a Sunday when no one can see them to get these teeth removed. So I think planning properly and seeing the patient at the right time, you can set up for the patient where they can do it in the upcoming months and not have to rush to take the teeth out. This, similar to the previous one, you can see the teeth are about 50% developed, the roots. You can clearly see the lowers, third molars, are not going to come into a good position. They're stuck behind the second molars. And at this time, there's no damage to the second molars, but taking these teeth out in the near future would definitely be beneficial to the patient. And again, these teeth are sitting nicely above the nerve, and the maxillary ones are sitting at a good location with the sinus where there's little concern of any sinus issues postoperatively. This next x-ray, you can see that lower wisdom teeth are a little more developed, and tooth number 32, you can actually is starting to encroach on the nerve. However, unlike the case with pericoronitis where you did a coronectomy, a developing tooth like this, where you have an open apex and an incomplete root, you have very little concern of any neurosensory disturbance postoperatively, as very little force will be needed to remove the tooth. Typically, these teeth move relatively easy, and the patient also have better healing capacity for the nerve to repair itself. So if there is an issue with the nerve, you're also going to heal better. This patient did have all 4 wisdom teeth removed, and the patient had no neurosensory disturbance postoperatively and healed very well. Now, looking at that white paper, this was kind of the summary that the American Association of Oral Maxillofacial Surgeons came up with, that the position and disposition of unerupted teeth has found to be dynamic and unpredictable. Therefore, the ultimate decision regarding the management of such teeth is best made by an expert clinician after clinical examination and review of factors such as age, position of the tooth, anticipated difficulty of removal, type of overlying prosthesis if there is one, and risks associated with the removal. By no means are we saying that every wisdom tooth should come out, but we do see a lot of issues with wisdom teeth that haven't been removed, and it's very tough to guess who's going to be that person to have an issue with wisdom teeth in the future. And by taking them out, or at least having them evaluated at an earlier age, you can try to stratify that risk. And if the patient thinks it makes sense, and we think it makes sense with the patient, take them out at an earlier age to prevent any issues for them. And it's always ideal for us to see patients sometimes before the teeth are even ready. There are many times we see patients for wisdom teeth and the teeth are still underdeveloped, and we have them follow up in a year or two, retake the pen and see if they're at the right time. By taking them out at the right time, it's an easier process for us as surgeons and as well for the patients themselves.
Okay, thank you so much, Dr. Fleischman. That was great. If anyone has any questions, now is the time. You can either unmute yourself if you feel comfortable, or you can write it in the chat and I will read it out for you.
Can I ask a question?
Yeah, of course.
Do you recommend, do you put your patients on any medication beforehand? I've heard of some oral surgeons that do that now. What's your protocol for afterwards? Just curious, what's your thought? Does everybody get an antibiotic?
So most impacted wisdom teeth, I do give an antibiotic to. I don't give anything preoperatively. If they're erupted wisdom teeth where I don't have to drill or section the tooth, I typically do not give antibiotics. But I feel once I start drilling bone or section a tooth, I do feel more comfortable giving antibiotics.
Thank you. Yep, thank you.
Okay, we have a message in the group, very informative. Thank you. So thank you, Dr. Fleischman. Does anyone else have any questions? Like I said before, if you want to unmute yourself, please feel free, or if you want to message in the chat. We have one here. How do you perform sedation?
How?
Yes.
So with a lot of times with taking out 4 wisdom teeth on late teens, early 20s, a lot of those patients do want to be sedated. We do also do it with laughing gas, nitrous oxide, or local anesthesia, but typically for all 4 wisdom teeth, we do sedate the patients. I personally, for my sedation, are they asking about like type of medication or?
Yeah, I think type of medication, maybe how common it is, like what's the most common?
Most 4 wisdom teeth on late teens, early 20s, the patients do get sedated. When I do sedate the patients, they typically get doses of Versed, ketamine, and propofol in varying doses based on weight and age of the patient.
Okay, great. Anyone else? If you'd like to ask any questions, please feel free. Get someone on mute. Oh, I have one right here. When do you do a coronectomy? When you do a coronectomy, does the exposed nerve ever get infected? If so, what do you do?
I've been doing coronectomy since I've been here. I've been in the practice about 6 years now. I've had one case where I had to go back and actually remove the remaining root. And it wasn't that it got infected. The patients had a little pain and discomfort in the area. The site wasn't healing well. The root was actually easier to remove, and the patient had no neurosensory disturbances. You really don't see much pain and discomfort after removal of the crown and leaving the exposed root. It's a non-caries tooth you can do these on. If there's gross caries in the tooth or caries to the nerve, you can't do the coronectomy. So you really don't see many issues with infection postoperatively from the coronectomy.
Okay, I have another few questions here. Do you use dexamethasone? And if so, when for inflammation reduction?
So I do use dexamethasone. I give it IV for my sedation patients. For patients that are with local or nitrous oxide, sometimes you can infiltrate some dexamethasone at the surgical site, or you can give a Medrol dose pack postoperatively. But I do give my sedation patients Dex IV.
Thank you. And I have another one. What is a good age to evaluate wisdom teeth or refer a patient to an oral surgeon?
It's tough. You see a very large spectrum of development of the wisdom teeth. I've seen patients as young as 14 or 15 who've had teeth that are ready to be extracted. I've seen 21, 22-year-olds who weren't ready yet. I think 15's on the young, maybe 16, 17 is kind of the ideal time to first get them evaluated. If they're not ready, they can always come back in 2 years, take another pan. I think it's easy enough to repeat the pan. It's very low dose radiation. And I think by getting them at the right time, it's just an easier procedure for the patient. They heal much better versus trying to take them out too early and really having to dig for the teeth, or waiting too long and having other issues with the wisdom teeth.
Dr. Fleischman, any closing remarks?
No, I mean, I just think they should evaluate the wisdom teeth. Get them in early to be evaluated. Make sure they don't have issues in the future.
Perfect. All right. Thank you, everybody. We're so glad you joined us, and we hope you have a great night.